Good evening, everyone. Thank you for joining us tonight for this webinar on practical insights into the National Lung Cancer Screening Program. My name is Ruby Van Cool, and I'm the Cancer Prevention and Control Program Officer with Central and Eastern Sydney Primary Health Network. I'm also joined tonight with Bertha Harvey from the CBD team. I'd like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people joining us tonight. Please note that this event is being recorded and will be available on the CESPN YouTube channel in the next couple of days. Please post any questions you have using the Q&A function. The chat function is disabled. At the end of the webinar, an evaluation survey will pop up on your screens. We really appreciate your feedback, and please complete this to allow us to issue your certificates of attendance. I will now introduce our first speaker for tonight's session, Tammy Shapiro, the Reviews Project Officer from HealthPathways Sydney. Thanks, Tammy.
Thanks, Ruby. Just going to share screen now. Bear with me. Okay, sorry, let's just get that show on the road. Can everyone see that okay? Wonderful. Good evening, everyone. It's a pleasure to be here. Thank you for the lovely introduction, Ruby. My name's Tammy. I'm representing the Health Pathways Sydney program, and just a quick introduction, an overview about some Health Pathways Sydney and Southeastern Sydney content that we've got with respect to the National Lung Cancer Screening Program. So just a reminder that CESPN is fortunate enough to have not one but two Health Pathways regions within our boundaries. So we've got Southeastern Sydney, which covers or aligns with the Southeastern Sydney Local Health District. And then we've got the Sydney team, whom I'm representing tonight, which aligns with the Sydney Local Health District. Sorry. Just a reminder, as many of you will already know, that since April this year, we've transitioned now to fully using individual logins for access. So those old generic usernames that we used for years of existence have now been retired, and access is only via a registered account. Just to remind everyone that you only need to register for an account once. You can register for multiple regions with that one account, so you no longer have to find the different usernames and passwords for different regions. There's many benefits to this, a few of which I'll try to talk about later in this presentation. Just a reminder that the generic usernames and passwords no longer work, and some reassurance that by enabling these accounts, it's not so we can track who's using what or who's looking at what. Program teams only get access to de-identified data, which is just used for reporting purposes only. So we get asked this question a lot in the CESPN region, as I mentioned. So we've got these two different health pathways teams. We often get asked, which region should I use? And basically, practitioners are allowed to use as many health pathway sites as they like. It ultimately, though, comes down to where their patient is going to be accessing services. So the Southeastern Sydney region is covering services within the Southeastern Sydney Local Health District. We're talking Royal Hospital for Women, St George, Prince of Wales, for example, whereas the Sydney site is covering services and hospitals within the Sydney Local Health District region. So we're thinking RPA, Canterbury, Balmain, Concord hospitals. At the end of the day, you could be working in Southeastern Sydney, but referring a patient to, say, RPA, in which case you'd want to have a look at Sydney Pathways, just because the information there, the models of care and the service information will reflect that region in terms of those services available. So I'm not going to go through every one of these. Just to let everyone know, these slides will be shared with everyone after the event. Both programs have a lot of content in the topic area that's going to be discussed tonight. In particular, we've both got a fairly new lung cancer screening pathway that was developed with the National Screening Program in mind, as well as various referral pages or request pages, as we call them, which contain all the referral and service information to complement that clinical pathway. So I'm not going to spend too much time on this because I know Dr. Martina Gleason's going to really cover it in terms of the practical aspects, but just to sort of give a quick overview, all of our clinical pathways, they follow a standard format. So whether you're using Sydney or Southeastern Sydney, you're going to see the same overall structure, which is assessment, management, and request. And request essentially means referral for services. Content is generally organized into what we call drop boxes. So you can see on the right-hand side there, I've got an example of a drop box, which is a key bit of information in the lung cancer screening pathway, which actually shows the user what to do based on the category rating from the low-dose CT report that comes out of the screening program. Couple of tips just in terms of usability. If you've never interacted with the content before, we recommend hitting the expand all button, which is in the top right of a pathway. That will open up a pathway in its entirety. It'll open all of those drop boxes, and it makes it easier to read through from start to finish. A nice little trick as well, if you're just really looking for something really particular, really specific, once you've expanded all of those drop boxes, if you hit Control F, you can then search for a very specific word. For example, I've put in there category 3, and if you hit enter, it'll take you right to where that appears. And it's showing me, for example, low to moderate risk, category 3, exactly what I need to do if the patient's report has come out in that finding. Another cool thing about the individual logins is we now have this feature called Smart Search. Smart Search is, like the name says, a bit of a smarter search. It allows a bit more capacity in terms of the search function. It also helps users navigate through content in particular. So that little option there, try Smart Search, will appear anytime that a user is searching in the main search bar. It is fairly new. It's backed by AI and it's a customized AI for this program. The nice thing about Smart Search, though, is that you can actually phrase a question in the Smart Search box, whereas the traditional search bar in Health Pathways is more for looking by symptoms or condition. You can actually pop in a question. So, for example, here I've put in who is eligible for lung cancer screening, and it tells me straight away, you know, here are some suggestions. It's rephrased it for me to say eligibility criteria for lung cancer screening. And if you click on any of those options on the left-hand side, it's going to then take you again exactly to where in the pathway that is mentioned, and it very nicely highlights it in yellow, as you can see here. So I encourage everyone to give that a go. Just to let you know, it is still a relatively new tool and it is improving with continual use. So as is the way with new technology, bear with us, but it's pretty exciting to see some of these new features coming through Health Pathways. The other key feature I just want to quickly touch on, which is also new with these individual accounts, is CPD reporting. So once a user has created an account, Health Pathways automatically tracks the amount of time that they spend looking at pathways. And this can be used to then write reflections and basically make a report for self-directed learning to whichever reporting body you're required to maintain your CPD. So it's automatically logging your use. Obviously, if you have the screen sitting there idle for some time and you haven't actually interacted with the content, the timer will stop. But if you're there interacting with the content, it's going to be recording the time that you're using it there. I want to be mindful of time, so I'm not going to go into very specific details about this, other than to say, once again, these slides will be circulated, and any member of either of the Health Pathways teams is always happy to assist any user in navigating this and learning how to use some of these new features, or just learning how to get a bit more familiar with the site if they'd like a bit more of an explanation there. And with that in mind, all of our program contact details will be circulated as well. And just a reminder that every single pathway we have has a send feedback button. I've got a little screenshot of that there. So we do encourage all users, if there's anything at all, whether you notice something, either it's not quite right or you'd like clarification, or you just want to say, hey, this is a great pathway. We always appreciate good feedback. That comes straight to our teams. We triage it on a daily basis. We do our best to get back to people as soon as that's received and action those things. So I encourage everyone to send as much feedback as you like, and yeah, look forward to hearing from everyone.
Thank you, Tammy.
That's right.
As Tammy mentioned, if anyone has any questions, feel free to use the Q&A box. and those slides will be shared with any contact details as well. So our next speaker for this evening is Professor Dorota Gertig. Since 2016, Dorota has been the Medical Director of the National Cancer Screening Register, playing a key role in the implementation and the operation of the register. I will just share these slides.
Right.
There you go. Thank you.
Thanks very much, Ruby, and good evening, everyone. I'll be speaking this evening about how the National Cancer Screening Register supports the new lung cancer screening program. And I'd also like to start by acknowledging the traditional custodians of country throughout Australia. And I am speaking to you today from the lands of the Wurundjeri people of the Kulin Nation and pay my respects to their elders past and present. Next slide, please. So I hope that the NCSR is by now familiar to many of you and that you interact with us regularly to support screening for your patients. The NCSR was enabled by NCSR legislation in 2016, and it presently supports the bowel cancer screening program, the cervical screening program, and since July, the lung cancer screening program. And whilst it's called a register, it really is much more than that. It's a national interoperable digital platform that supports all of the operations of these cancer screening programs. And it has a number of key functions. So firstly, it maximises participation by inviting and reminding participants to screen based on Medicare eligibility. Now, obviously, lung cancer is a targeted program for high-risk people. So unlike bowel and cervical screening, where it's based on age and sex, we will invite participants after they've been enrolled by their healthcare provider. So that enrolment process is really quite important for lung screening. We also perform an important fail-safe function for following up screen-detected abnormalities by applying consistent rules that align with clinical guidelines. And we also inform continuous improvement and evaluation of the screening program by providing reporting to the jurisdictions, to the Commonwealth, and to the Australian Institute of Health and Welfare for safety, quality, and evaluation of the screening programs. Next slide, please. So this slide shows how the NCSR supports connected care across the screening ecosystem. So we're leveraging all of the digital functionality to support lung cancer screening. So the participant record is really at the heart of the NCSR. There's a single record for all the screening programs, again, based on the Medicare record. And we receive a daily feed from Services Australia that updates demographic information. There are two main ways that healthcare providers can integrate digitally with the NCSR and with the lung screening program. That is through the healthcare provider portal or through integration with your clinical information systems. So we're presently integrated with Best Practice, Medical Director, Communicare, and also now MMEX. So we integrate with 80% of the software that's used in medical practices in Australia, and I'll come back to that in a moment. We're also digitally integrated with all the major pathology laboratories, and we're integrating with the radiology information system so that we receive the structured low-dose CT scan reports electronically by HL7 messaging. We also have a range of other functions to support the screening program shown there at the top of the slide, including a mail house for the bowel kits, and also a participant portal that's accessible through MyGov. So their participants can update their information, they can view the program correspondence, select communications preferences, and also view their next screening action. And as I mentioned, we have the business intelligence and reporting functions. Next slide, please. So the NCSR will receive key program information by leveraging the digital foundations that I've described. So this is for the lung cancer screening program. So it begins with enrolment by the GP. So at the point of the GP visit, the enrolment form is submitted to the NCSR via the portal or via clinical software integration. And it is an important step and one we do try to make as easy as possible. And I'll show a brief video in just a moment. It is important for program monitoring. And also, if you enroll your patient and they don't subsequently have a scan, then the NCSR will remind them to have their scan at the appropriate interval. The radiologist then conducts an assessment of the low-dose CT scan using the nodule management protocol, and they submit a structured report both to the NCSR and obviously back to the referring provider. If the participant's at high risk of lung cancer based on the low-dose CT scan results, or if they're a category 5 or 6, they will be referred to a specialist, and that referral form can also be submitted via the NCSR portal or the integration, as well as there's a form on our website. Specialists send the clinical diagnosis form to the NCSR through the portal, and that's the main way we're going to receive timely information on staging. And we'll also trigger exclusion of participants from screening pathways if that's relevant. And we'll also receive the histopathology reports electronically from the integrated laboratories. We are committed to ensuring high quality and complete information, so we will receive the MBS item numbers for screening, and we'll use that to benchmark the data, and we'll actively follow up missing information. And next slide, please. So the NCSR supports the entire screening pathway for lung cancer screening. So not only do we capture information, as I've just described, but we also send communications on behalf of the program at key touch points, both to the healthcare provider and also to the participant. So these can be by SMS, mail, or follow-up phone call if it's urgent, and depending on the participant preferences. So I'm not going to go through each point here in the screening pathway, but just to highlight a few examples of how we interact with both yourselves and the patients. So when participants enrolled in the program, we will send a welcome letter. When the scan is completed, we'll send correspondence both to yourselves and to participants with next steps, depending on the low-dose CT scan result. And if a specialist referral is required for a Cat 5 or 6 result, we trigger fail-safe follow-up activity, and that might include a phone call to the specialist. And then when the patient's due to rescreen, we'll send rescreen invitations and reminders based on the risk categories shown on the right-hand side there. So in this way, we're supporting all of the key stakeholders along the screening journey. Next slide, please. So there are two main channels, as I've mentioned, for digital interaction with the register. And I hope you're becoming familiar with this functionality. And so the functionality for these two channels is actually the same. You can access your patient's bowel, cervical, and lung cancer screening information. Submit the program clinical and diagnostic forms electronically. You can manage your patient's details and communications preferences, and also order bowel kits to your patient's address, or also now you can order them in bulk to your practice. We have over 4,000 practices integrated across Australia and about 25,000 active users of the healthcare provider portal. And as adoption increases, we've seen a big move away from faxes, thankfully, with a 94% reduction in fax cervical screening history requests. And also importantly, through the healthcare provider portal, you can delegate access to your clinic staff to help with clinic management. So I'm now going to show a brief video of how to complete the eligibility and enrolment form in the healthcare provider portal. It can also be done through your clinical software integration. So this form will, yes, if you could press play, that'd be great. Thank you. This form will automatically open after you've searched for your participant. And in the healthcare provider portal, the provider details will pre-populate, but you can make updates by using the provider lookup. And in the next screen, you'll see how you can use the lookup and then enter your provider details. If you work within an ACHO, please select yes under organisation details. And then you'll select whether your patient is eligible for the program, and also confirm the patient consents to share their data with the NCSR and to receive notifications. And they can also suspend contact with the NCSR, but remain a program participant, but just not receive correspondence. You'll then confirm that the patient is suitable to receive a low-dose CT scan, or you can add a date after which they'll become suitable. And then the next part of the form includes smoking cessation information and clinical history as to whether they have a family history of lung cancer. And then the last section is demographic information and whether they require an interpreter service. Once you've completed the form, click on review. If everything's correct, hit submit, and your patient will then be enrolled in the program. So you'll see here, the alert will immediately show on the portal that they are now eligible for the National Lung Cancer Screening Program. And just to note that if your patient does opt out of the NCSR, they will still be able to claim the MBS item numbers for screening, and they can still participate in the program, but the NCSR won't receive any of their screening results or correspondence, so we can't provide a safety net function if they've opted out. Next slide, please. So for any practices yet to integrate their system with the NCSR, I think we're playing the video again. Yeah, that's the one. Or wanting to access the healthcare provider portal, we have a toolkit with all the information that you need through the one-off registration process and to set up the system. So practices can also call us or book in some time with one of our experts who can walk you through the whole onboarding process. So when preparing to register, you'll need ABN details, your HPIO, and also have a responsible officer allocated for the practice. And to avoid any issues with integration, we'd also recommend that practices confirm that they have FHIR correctly installed, that's FHIR, a technical term, and configured including firewall ports for best practice users, and also that you have the latest version of best practice or medical director. And as I said, you can contact us for support if issues persist, so we can help track and resolve problems. Now, I do apologise to anyone who has tried to access the system today, as we have had an outage due to a technical issue, but usually everything is fine. Next slide, please. So as we're well into the lung screening program, I strongly encourage you to register for digital access to the NCSR if you haven't done so already. And thank you to you and your teams who provided excellent support to connect your practices. And as I said, we now see that the latest data shows that we have actually it's almost 4,500 practices registered now. So thanks for your attention. I'm happy to answer questions at the end, and I'm passing, I think, back to you now, Ruby.
Thank you, Dorota. Yeah, a good reminder that if you aren't already integrated, to either reach out to the NCSR or get in touch with your digital health officer at the PHN who can help as well. I'll now be handing over to Dr. Martina Gleeson. Martina wears many hats, but one of which she is a very experienced GP in Caringbah. And I'm just handing across to her for a practical insights from a primary care perspective. Thanks, Martina.
Thanks, Ruby. You want to share my slides? And thanks, Dorota, for your talk. Maybe before I get started, I just want to say I gave Dorota the heads up. I've spoken to a lot of colleagues who said to me, I'm just not going to enroll them because it's too much paperwork. What happens if the GP doesn't enroll the patient before they give them the form to go and have the low-dose CT scan?
Oh, would you like me to answer that now, Martina?
Yeah, you may as well, and then I can go through my presentation.
Look, it is a question we do get asked quite frequently, and as I've mentioned, it is a really important step for program monitoring. And also, if you enroll the patient, but then they don't subsequently scan, because the NCSR has that information, we can then remind them to scan if they've just forgotten to do it or if they're not sure. If you don't enroll the patient, there is a sort of safety net function where when we receive the MBS item number, we can still trigger some of the correspondence and follow up. But we strongly recommend that you do complete the enrolment form. And I hope, as I showed in the video, once you get used to it, it is really quite simple to complete, and a lot of it is pre-populated, but it does require that initial step of integration. And there obviously are lots of other benefits in terms of the other cancer screening programs.
I have to say we had a bit of trouble integrating, but once we got it sorted, it's so functional. I love having it integrated into the software. It's made everything so much easier. So thanks for that. And just clarifying, the radiology practices won't enroll the patients for us.
No, the radiology practices won't. They won't have all the information that you have when you see the
Yeah.
patient, and their
Yeah.
workflow is not set up for that.
All right, good, thank you. So Ruby, next slide, please. This is just a picture of the fact that there is a health pathway on both Southeastern Sydney and Sydney about the lung cancer screening program. It's available across the whole of Australia, and nearly like everyone has almost the same content. So it's really hopefully has all of the information you need to start enrolling your patients and taking them through the program. You will go down to the next slide, Ruby. And going through the eligibility, just in case you haven't gone through it, they have to be aged 50 to 70. If they're 72, even if you think that they might like to be screened, they're not eligible through this program, but you can talk to them about what to do from there. They need a 30-pack year of tobacco, cigarette smoking history, which includes packaged cigarettes and roll your own cigarettes, but doesn't include other forms of tobacco or nicotine smoking or consumption like vaping. A one packet is 20 cigarettes, even though obviously they're sold in bigger sizes these days. They need to be currently smoking or quit in the last 10 years, and they need to have no signs or symptoms suggestive of lung cancer. Next slide. So identifying eligible patients in practice. So these are like practical tips. So try to make sure that their smoking history is up to date. And the points where you might do that is when they're admitted to the practice. If you're doing a yearly update of patient data, which a lot of us try to do. And also if you use pre-consult questionnaires, then you can add a smoking history into the pre-consult, which might flag that the patient might be eligible. Also consider incorporating an eligibility for lung cancer screening assessment in some of your chronic disease management items, like when your nurses are helping you with preparation of chronic disease management plans, making sure they update the smoking history and consider eligibility. You can do a data search and if your smoking history is up to date, that's helpful. And health assessments like menopause assessments, why not do a smoking history and look and see if the patient might be eligible if they're already over 50. And if they're not 50, they're 48 and perimenopausal, a good opportunity to say you will be eligible when you turn 50. And that might instigate a smoking cessation discussion. You can also design some practice quality improvement activities and do it as a measuring outcomes activity for the whole practice. And you can also put stuff in your practice newsletter or your social media about lung cancer screening that invites patients to self-identify and to ask your doctor. Next slide, please. So when you're doing your eligibility, the next thing to do is to see if they've got symptoms, because if they have any symptoms that might indicate that they could have lung cancer, like a chronic cough that's been there for longer than 3 weeks, or blood in their mucus, or any of those symptoms, then really you have to follow the suspected lung cancer pathway. So that's actually following up a symptom. Just like a breast lump means that they don't have a breast screen mammogram, they have a diagnostic mammogram. If they've got symptoms of lung cancer, then that's a different pathway. Next slide. And there's a really helpful tool called the Investigating Symptoms of Lung Cancer tool, and there's a link to it in the Health Pathway. But you can actually open this up and go through the symptoms that the patient has as you go through the tool, and then it will come out with an answer for you as to what the next test should be, whether it should be a chest X-ray or a CT. And that can be really helpful for the patient to see you go through that and make a decision together about what to do. Next slide. So ongoing assessing eligibility. And can I just point out, like, this is actually quite a lot of work. So one of my practical tips is once I've identified that the patient might be eligible for screening, actually tell them to make an appointment. I've never apologized for asking patients to make an appointment for their pap smear. And I think this is a similar thing. Once you've identified a patient's eligible for screening, the time you take to do it properly is worth the patient making an appointment and coming in, rather than trying to tack it on and then blowing out your appointment because, you know, the patient came with their agenda and your agenda is to do this assessment. after we've been doing this for a couple of years, we'll be checking their previous lung cancer screening history because they may have already had it and seeing when they're next due. And then we also have to check their current suitability. If they can lie flat for a minimum of 5 minutes and be able to hold their hands above their head. And some people are so breathless that they can't do that. Make sure that they haven't had a symptomatic lung infection within the last 12 weeks, because that might mean that there are parts of the lung that are not accessible by the CT scan. And make sure they haven't had a full CT of the chest within the last 12 months or have one planned in the next 3 months for other clinical reasons. Because if they have had that, then probably there's been a nodule assessment already done. Next slide, please. When you're talking to the patient, I've been really struck in practice about how stigmatized and self-judgmental some of my patients who continue to smoke are. When I bring up lung cancer screening, they're so self-judgmental, they kind of feel ashamed, and they're very, very worried about having lung cancer. So it's very important to try avoiding stigmatizing and blame language. I found it really helpful to blame the tobacco companies for deliberately making them addicted rather than looking at it as some kind of moral weakness that they still smoke. Reassure the patient that they don't have to give up smoking to be screened. It's a good idea it's a good opportunity to support smoking cessation when you're going through the assessment. And there's some patient information on the lung cancer screening, and it's easy to find in the health pathway in the for patient section right down the bottom. The whole aim of this is early diagnosis so that we can actually have successful treatment. The radiation dose is very low, and with screening, 70 out of 100 cancers can be found early, which is really good news. The whole point is to try and avoid people being given a diagnosis that's a death threat, but rather a diagnosis that means they can have treatment and continue to live a good life. Next slide, please. Just talking about paperwork. We do need to enroll the patient in the National Lung Cancer Screening Program. Dorota was just talking about that. But, you know, in terms of our workflow, it doesn't necessarily have to be the doctor that does that. So it's possible that you can nominate one of your admin staff to be a delegate and they can do the enrolment, or you can get your practice nurse to do it if you think that is a better use of their time than your time. So think creatively about how you might help yourself with that paperwork. Although I have to say, now that I've worked out how to do it, it doesn't take that long. But you know, we're always trying to be efficient and get the best use of our time. Once you've enrolled them, then there's a low dose CT scan imaging request form template, and it's available in most clinical software. But it's available as a letter rather than an order form. So you'll find it in your letters templates. And if you search NLCSP, it will come up. And you do need to provide information regarding the family history of lung cancer, as well as all of the other demographic information when you're doing the order form. And plan follow-up. This is another one of my practical tips. I've got to the point now where I actually say to the patient, Ruby, can we go to the next slide? Oh, no, don't go to the next slide just yet. I've actually got to the point where I say to my patients, I haven't had a report back yet that hasn't had something to discuss. It's not necessarily the nodules that need to be discussed, but there's often something else. So rather than having you panic when you get a notification from us saying there's something wrong with your CT scan, please make an appointment. Let's just set up an appointment to discuss the results. And we can cancel it if there's absolutely nothing because everything's perfect. And I find that the patients are a lot happier to make that appointment knowing that they'll be coming in to discuss the results rather than anxiously waiting to see what their text message says when we see the results. Next slide, please, Ruby. The reporting has two main sections. There's a report on the nodules and what follow-up needs to be done. And it will also tell you, exactly what follow-up needs to be done. So that's helpful. And then there's another section of it that says additional actionable for findings, where they will report on things like other things found in the lungs, like bronchiectasis or scarring or some fibrosis. It'll report on the pleura, things in the mediastinum, cardiovascular, so it will report on calcium in the coronary arteries, but not as a calcium score. It will report on some findings in the upper abdomen, possibly in the breast, the thyroid and the bone. So as you can see, there's actually quite a lot of possible things that that will be in the report. And the additional actionable findings are reported in a way that is recommended in a guideline by the Royal Australian and New Zealand College of Radiologists. It's a very standardised way of reporting. So it will give you an idea of what follow-up needs to be done, and there'll be health pathways to support that. Don't rescreen the nodules too early. Follow the instructions. So if it says rescreen in 3 months, don't do it in 2 months because the patient's anxious. We need the interval so we can see what's happening. Next slide, please. So practical tips, as I already said, warn the patient there's nearly always something to discuss. Book a follow-up appointment for 2 weeks after the test because I'm finding it takes a little while to get the results. You can always bring them in earlier if you need to. Reinforce smoking cessation support and use your recalls. If you've got a patient that has to have another scan in 3 or 6 months, when you get them back for the appointment to discuss the results, you can give the patient the form for the next scan and set up a reminder for them. They don't have to come in to see you in 3 or 6 months just to get the order form to have the next scan. Next slide. If there's a high or very high risk nodule, you'll find that both of the health pathways will show you where to get a rapid assessment of that. So in the southeastern Sydney, it's in the specialised lung cancer assessment page, and there's a link to that on the lung cancer screening pathway if you can't remember that. And in the Sydney pathway, it's on urgent respiratory assessment. But both of them, you will actually see rapid access lung nodule clinic and the contact details for those clinics in your area. Or the alternative is to go onto the Can Refer website and search for multidisciplinary team for lung cancer in your area, and it will tell you the private respiratory physicians who you could refer to if that's what your patient prefers. Next slide. And this is just a list. Tammy's already done it, so I won't spend a lot of time. But because the CT scan is going to show a lot of details, you may find some of these additional relevant pathways helpful, like emphysema or interstitial lung disease, bronchiectasis. So how to manage the conditions that the screening CT shows. And Ruby, I think that's everything. So
That's it.
thank you.
Thanks, Martina. And again, if you have any questions, just use the Q&A down the bottom and we'll come to those at the end. Our final speaker for this evening is Professor Catherine Jones, a thoracic radiologist working at iMed Radiology and the Royal Brisbane Hospital. She has been part of the clinical team designing the lung cancer screening program and is a professor of clinical imaging science at the University of Sydney. Thanks, Catherine.
You might stop sharing mine, Ruby, so Catherine can.
Oh, thank you. There we go.
All right. Thank you, everybody. Hopefully you can see my screen okay there. First of all, thank you for the invitation to speak today. I do feel as though quite a bit of what I might be saying has already been said by Dorota and Martina. So I'll skip through anything that I feel could be a duplication. I'm an executive member of the Australian and New Zealand Society of Thoracic Radiology, and one of my great professional satisfactions, if you like, has been part of the design team for this National Lung Cancer Screening Program for about the last 2.5 years. There's a team of about 12 clinicians from different craft groups from around the country that have put together this program from a clinical evidence-based perspective. And the ANZ STR has done a huge amount of the work, but to acknowledge this has been a collaborative effort, from the GPs, the thoracic surgeons, the respiratory physicians, the oncologists, from everybody. I wanted to run through a few things today that are particularly, GP relevant. The first thing is the request form. So I get asked this question all the time. And the question I always get is, do I have to use the template? Do I have to use this formal template? No, you don't. But you do need to put in a particular set of information. First of all, it has to say that it's for the National Lung Cancer Screening Program. You'd be surprised by how many people haven't written that in the form and seem surprised when that hasn't been scanned in the right way. It must also include that the person is eligible, and I'll talk about that in a minute. We do also get referrals from outside the GP group, so some nurse practitioners, for example, particularly in regional and remote areas, as well as non-GP specialists, although that is a very small proportion overall so far of the referrals that we've had. So this is what the official form looks like. There's a couple of things that I, as a reporting radiologist who do a lot of these cases, would really like to see ticks, or at least a mention of whether the family history is positive, and just noting that that is a first-degree relative who had lung cancer. So not lung metastases from something else, not your aunt, not your second cousin, not your friend from high school, like somebody, first-degree relative who had primary lung cancer. It can be any type of lung cancer, doesn't have to be a particular subtype, and it can include, things like carcinoid. Now, it's really helpful to us as well to know if there's a previous CT chest out there for us to go hunting. The more information you can give us about that previous study, the better, because when it comes to knowing whether a nodule is malignant, knowing what it looked like in the past and how it's behaving is a really key component, as I'll explain in a minute. There are 2 MBS item numbers that are new for this program. One of them is for the baseline study, which simply means the very first scan that's been performed for this participant in this particular program. Every subsequent CT scan that that participant has as part of this program just has the interval imaging or follow-up imaging item number. So please tell me the family history. And the reason for that is I need to know what it is to put it into my risk calculator. Tell me if they've already got a history of cancer. It's kind of useful to know. And in fact, I would suggest every time you request a CT chest at all, please give me the personal history of cancer. It's a really important thing for us as radiologists reporting. And because that tells us whether or not we should be using the screening nodule protocol or whether we should be taking another route. And again, like the prior CT is really important for us when we do our comparison. So very different for us if the person's coming in at their baseline study, so the very first time they've ever been scanned. Very different story to say someone who was previously a category 3 intermediate risk and has come back for follow-up. It's a very different report that we're going to give you. This one. So somebody came in, had pneumonia. We said, you know what, come back in 3 months. We come back, maybe they're overdue now for their follow-up for another nodule because they had pneumonia. And maybe they had a high-risk lesion and they got referred to the respiratory physician. They went to a multidisciplinary team meeting. They got cleared of any cancer, and now they're representing for screening. So the more of that relevant information you can give us on the form, the better, because it really does change the way that we interpret the images on that day. So this is the nodule management protocol. These were developed by the ANZ Society of Thoracic Radiologists as well as the Thoracic Society of ANZ. The protocol essentially picks the best out of different regimes around the world, not just for the baseline protocol, but also what happens when people come back for follow-up imaging, as well as the guidance on what likelihood a nodule has of being malignant. We also recommend when that person should come back for follow-up imaging. We also have this really, I think, I might be biased, quite well-written document which goes through some of the explanatory notes around how we came up with this protocol. If anyone's interested in reading, it's a fairly short document, but I think it's quite well written. At baseline, when you come in and you've never had a CT of that part of your lung before, we use something called the PanCan or the Pan-Canadian nodule malignancy risk calculator. And this was published initially about 15 years ago as a way of triaging out nodules at the very first time you see someone on a CT to say whether or not it's safe to bring them back in 2 years. And by safe, I mean it will either be stable, resolved, or so slowly growing that it's still very treatable at stage 1 in 2 years' time. And you can see the elements that the calculator include age and sex, the family history, and that's why it's so important that we have this, particularly at their baseline assessment, whether we can see any emphysema on the CT, how big the nodule is, what kind of nodule it is, where it is, how many there are, and is it spiculated or like this horrible irregular shape to it. We put all of that in, we do that, that's our job. And it produces a cancer probability. And that probability then leads on for us to determine the recommendation for the study. So when we have a nodule, we look at that PanCan calculator and we say, what's the chance that this is malignancy? And so for the nodule we had before, I think it was about a 22% risk. That fits into the 10 to 30% category, which equates to coming back in 3 months for a low dose CT for a quick check. Okay, we want to see what's happening. We don't think it's bad enough to go straight to the respiratory team, straight for review, because quite a few of these nasty looking things turn out to be infection or inflammation, and it's safe to bring them back at 3 months. And obviously, if you have a lower risk in your calculator, we can be more confident about bringing them back in a later time frame, either 6, 12, or 24 months. If you have nodules that are very low risk, less than 1.5% chance of cancer, or in fact, no nodules at all. And so this is what we call our category system. And this is a bespoke category system. It doesn't match up with any of the other programs around the world because, you know, why would we? We have to make our own. But actually, again, I'm very biased, but given the amount of time and effort from a lot of people with a lot of experience in screening and radiology and nodule assessment, I genuinely think this is the best combination of all of the different things from around the world. So at baseline, or in fact, even afterwards, if you have a category 1 lesion, then we're going to get you back in 2 years' time. So that's very low risk. A category 2 lesion, we're going to get you back in 12 months. Category 3 lesion in 6 months, category 4 in 3 months, and category 5 and 6 is kind of heading up to the dodgy end of the spectrum where we're saying, actually, we think this is bad enough that you need to go straight to a respiratory team that has access to a lung cancer MDT. Now, let's go through a little bit about what happens at follow-up. Now, you'll see that we're still using category 4, category 3, category 2, category 1. So those definitions haven't changed. And the recommendation for when someone comes back, so category 4 is still come back in 3 months. Okay, so that's consistent across the whole program. But if you've had a category 4 lesion and you come back in 3 months and you do the right thing, have your follow-up scan, and it hasn't changed, so it's stable, that's reassuring. So stability is reassuring. And that means that you can now be treated like it's a category 3 nodule. So then we say, right, come back in 6 months' time. And so over time, you step down from the pointy end, the dodgy end of the spectrum, back down hopefully to category 1, where you can re-enter 2-year cycling. And of course, if you have more than one nodule, you go to the highest, most risky one to give you the overall category for the study. So if you have a category 2 nodule and a category 4 nodule on the same CT, overall, you're a category 4 for the whole study. These are just some examples of some of the things we've already started seeing on follow-up when some people getting back at 3 months already. And when we have 3 months, then we, rather than looking at just what the original Risk is based on your family history, for example. We now look at each individual nodule and we say, how's it behaving in terms of its size and any other imaging characteristics that may have changed. There's a couple of special cases because, of course, there's always a special child in the class. And atypical pulmonary cysts is one of them. We know that this is a type of cancer that is traditionally highly underdiagnosed by radiologists. And in other screening programs, they haven't been included. So we've included them in ours. This is not something that we can put through a PanCan calculator because it hasn't been designed to do that. But if we see one of these on baseline, we get them back in 3 months for a quick look to see if it's an aggressive type of cystic lesion. And if it does progress, it can look all sorts of funny things. For example, it could actually be the same size, but just have more little lines and membranes inside of it. They are all features that are specific to this type of lung cancer, and we deal with that in our follow-up protocol. You'll get a structured report, or at least you should get a structured report if people are doing the right thing. And in that report, you'll see a number or a category for the whole study. You'll get a recommendation as part of that category as to whether to send to the MDT referred team or at what time interval they should be coming back for their next test. We also have the actionable additional findings, which you've already heard about, and there's tons of those, tons of those in this population. And you'll get a series of recommendations that have been, standardized across the program. If you do refer them to the lung cancer team, that's either category 5 or category 6. Anything that's done after that point by that team is not part of the program. Okay, but as we've already heard from Dorota, the diagnosis made by that MDT team will be sent back to the NCSR so that we have visibility about what happens to those people. Once, from a radiology perspective, we treat them like every other person that's been referred for follow-up biopsy, PET scanning. We don't have to follow the nodule protocol because we're no longer screening. But if that person is cleared of having cancer and they're deemed eligible by the respiratory team to go back into the screening program, then we go back using the same low-dose protocol, and now we use the follow-up management because we have something to compare to. But as with everything else in radiology, the more information we have about all of this happening, the better. Otherwise, you could show up, have no idea that this has all happened, and say, oh, I think there's a terrible looking lesion here, and send that poor person around, the cycle again. But what's it looking like so far? Well, I mean, it's been busy, and that's fantastic. It's been a pretty high uptake. Over the first 3 months, we've already had more than 25,000 participants enrolled and screened, actually scanned around Australia. Most cases are negative, and that's what we expect from a screening program. And by negative, I mean there's no nodules or very low risk nodules, and they're coming back with a recommendation for 2-year follow-up. About 1.5% of people have a category 5 or category 6 overall category, which means that they get referred for immediate review, which is a little lower than we were expecting, which our respiratory colleagues are happy about, but I think perhaps we haven't seen the worst of them yet. And most cases have at least one additional finding, an emphysema, coronary calcification, and osteopenia, osteoporosis that reduce bone density. They're the 3 most common ones. I'm going to switch now to doing some slides from my own personal practice at IMED, where we've done about a quarter of all of the scans that have come through the program. I audited the first 4,606 cases, which is a very random number, but that was the number we'd done by the deadline I had to present a presentation on this. So that's why it's an odd number. We collected every data field in every NSCLP report, and we looked at what we found. Interestingly, 7% of our cases, despite saying that they had not had pneumonia in the last 3 months, had something that looked infective or inflammation or inflamed, which I frankly put down as the winter effect because we started on the 1st of July. Of that total number of cases, slightly slanted towards male participants, and nearly 15% had a positive family history of lung cancer, which when you consider it's the most common cause of cancer death and the 5th most common cause of cancer in Australia is probably not that surprising. When we talk about how many nodules we had that were reportable, well, again, we had 705 cases, so 15% of them had something on them. So that's the 15% that's not negative. When we looked at people who are aged under 60, so in the 50 to 60 range, 12% of them had nodules. And 60 to 70 years of age, it went up to nearly 18%. So not surprising that as we age, we tend to get more likelihood of disease. Overall, luckily, we didn't have a huge number that were down in category 5 and 6, which is the really nasty end, about 1.5% in total. And we had a smattering of category 2, 3s, and 4s. What type of nodules were we seeing? Well, we're seeing solid ones for the majority, which is what we would expect to see. That's what most lung cancers look like. But we also have the non-solid or ground glass kind of fluffy looking things. We had part solid nodules, airway cysts, all sorts of things. And so this is, again, pretty much what we're expecting to see from the program. Here's the effective age, not only on how many nodules were found that needed to be reported on, but also whether or not those nodules that were found were nasty. And you could see that once you hit the age of 60, the risk of having a nodule that needed to be referred immediately went up by 3 times. So again, that effective age within the group. What about the positive family history? Did it turn out to be significant? Well, I mean, it did. Positive family history versus negative family history, reportable nodules were similar, but it was, nearly twice the number of them were category 5 or 6 for immediate referral to an MDT team. And because I'm a statistician, I also decided to do a bit more of a deep dive, which I won't go into too much today, but suffice to say that if you're under 60 with no positive family history, your chances of needing immediate referral for what's a pretty nasty looking cancer was only 0.6%. Compare that to over 60 with a positive family history, it's nearly 4 times at 2.2%. So we already know, even though these are all high-risk people, we already know which ones are the highest risk. So particularly for the older people in your practice with a positive family history, please do consider asking them if they'd like to participate in the program. I just finish on some additional findings. There's lots of people who have emphysema in this group. It's about 40%. Okay, so that's nearly half. We can see emphysema there. Again, most people have coronary artery disease, between ages 50 to 70 and smoking. There's going to be a lot of that as well. We mention it, okay, but it doesn't mean that you have to send to a cardiologist. In fact, the cardiologists are kind of saying, we don't want you to send us all this work. This is the remit of GPs. Again, there's other things like bronchiectasis, interstitial lung abnormalities, which is a radiology term for when we see something that could maybe turn into interstitial fibrosis. And the high-risk features, it could be interstitial fibrosis already. And that's, again, very prescriptive recommendation for what to do next for these cases. We do also see abnormalities of the thoracic aorta, pulmonary arteries, a few mediastinal masses, and some enlarged nodes, all sorts of things that you might see people presenting with in that age group. I do want to highlight a couple of things. The breast lesions. Now, given that most breast lesions don't happen in the male participants, a 0.9% risk is actually about a 2% risk overall for the women participating in this program. And there's a lot of evidence that if you are at risk of breast cancer, you're also at risk of smoking-related disease. So we have about a 2% pickup rate of suspicious lesions on CT. CT is pretty poor at looking at breast lesions. Okay, it's got nowhere near the accuracy of mammogram or ultrasound. And so if something's bad enough for us to see it on CT, it's got to be pretty bad. So this is an unexpectedly high number. And we're also seeing a smattering of other, thankfully rarer things. I will draw the attention down there to reduced bone density and vertebral fractures. It's nearly 30% of our participants have these features, which are very strongly associated with osteoporosis. That's higher than we were expecting. And when one of these two things is found, then the recommendation is to have a bone densitometry test. So just to summarize my my section of the talk today, GPs are completely vital to this whole recruitment, enrollment. I would also reiterate how important it is to enroll your participants into the register. It is a safety net, and it gives so much more nuancing and complexity to the data that we're able to achieve out of this. Our job as the radiologists will be to provide a structured report after we've done the appropriate type of scan, and we send that to you. So you should get a structured report from us, which has all of those sections in it. And then we also send the fields from that report off to the register. But most cases are still going to be negative or very low risk. And even the ones that are reportable with nodules, the minority end up needing to have an immediate referral. I'm hoping that the winter effect of 7% having infective or inflammatory features and needing to come back for review will drop off over the summer. And the most most relevant thing in most of our participants isn't that we find anything that looks like lung cancer, but we might find something else. Okay, so emphysema, coronary artery disease, and reduced bone density. They're the three big ones. And that's it for me. I would like to acknowledge that this is not a solo effort. There's a ton of people, particularly those people in that steering committee from the Radiology College, who've put a lot of work into this program as well. Thank you.
Thanks so much, Catherine. That was really, really helpful. It doesn't look like we have any questions. I don't know, Martina, if you have any questions from a
I've got a
GP
question for
perspective.
Catherine. Yeah, Catherine, if I had a patient who was 69 when they entered the program and they actually had something that needed follow-up, but by the time they follow up, they've turned 70, what happens in that situation? Because obviously they still need follow-up, but they're aging out.
Well, we can't actually just ignore them.
No, of course we can't.
So I've created a macro, which has been adopted by a lot of the other radiology practices, and it's literally called aging out, which is a little macro that we put into the report that says, at the time of the next recommended scan, this participant will be over the eligible age to participate in the program. However, we recommend that this scan should still be done. And because this is now not screening, but you're following up an abnormality, that's completely fine to do that under normal Medicare, rebatable
Medicare
CT
rebatable.
chest. Under any normal lung nodule follow-up protocol, it's Medicare rebatable. So bring them back at the right time, but it's just not part of the program anymore.
Your talk was really valuable in helping us understand how helpful it is to provide you with as much clinical information as we can in order to make the reports that we're receiving meaningful. And it also validated my practice of saying nearly everybody's got something to talk about, so please make an appointment to see me.
100%.
I think that sets a realistic expectation for the patient.
100%. Couldn't agree more. And, we know from how we designed this program that we're only reporting things as additional findings that we think are going to impact someone's future health. So we're not going to report simple cysts in the thyroid or the liver or the kidneys, that sort of thing. We're not going to report little bits of scarring in the lungs that doesn't mean anything to anyone.
It's really
leaving that
valuable
out.
to say to someone who's 55, well, we can see emphysema in your lungs and your coronary arteries are already calcified. How's that smoking going for you? It can be quite motivating to people go, oh, that thing I feared is happening and I'm actually showing the changes. It's an opportunity to suggest. We do have a question. I knew once I started asking someone else would ask. Who is responsible medico-legally for incidental findings? If the reports are now available to patients without seeing a doctor and the patient does not follow up with the doctor because lots of patients see different GPs in many different clinics. I think I know the answer to that.
Do you want to start, Martina, and I can follow?
Well, I think medico-legally, the doctor who ordered the test is responsible for making sure the results are given to the patient.
Yeah, I agree with that. I think as well as that, that's another benefit of enrolling somebody into the register. You know, they'll get a reminder to go and, you know, follow up what needs to be done. A lot of the prescriptive recommendations are to suggest follow-up, to suggest clinical consideration, you know, to consider referral. And so that gives a lot of leeway to the referrer, because you may already know that this person has emphysema. It might be something they're already on treatment for. They may already be on treatment for their coronary artery disease because they know they've got calcification. So you know, we're not ever recommending that you have to go and send them to someone else. It's up to you to put it into the context of their bigger health picture. But ultimately, and it's the same across the whole of radiology, you know, if we send out a report and the patient now has access to it because they can access things, maybe they will look at it and go, oh yeah, I'm not worried about that, and not come back and see the referrer. It's the same across the whole of radiology and pathology and everything else. So it is up to the referrer to make best efforts to get that person to come back in.
And most practices should have a policy for how they follow up clinically significant results. And as an example, because I'm the practical tips person today, our practice sends out 2 SMS messages saying you need to discuss, and then we'll either try to phone the patient or we'll send them a registered mail saying we've attempted to contact you. We realise you may have seen your results already. You know, it is important that you discuss this result with someone, but this is the last time we'll attempt to contact you about it. And then I'll still leave an open thing so that if the patient turns up in 6 months' time, there's a reminder to me to discuss that result. Maybe I'm a little bit OCD about it, but you know, I can lie straight in bed and not be worried that there's going to be a complaint about me. So I think
it's really important though. I mean, I'd like to think that this is routine across the sector. Where I work, we have an admin team dedicated just for this program, and if there's something there that either looks concerning for lung cancer or a significant additional finding, we ring the GP that day and say, hey, you know, can you please get onto this? Just to make sure that it doesn't slip through the cracks between the radiology clinic and the referrer. But that again is another reason to enroll your person into the NCSR.
And if you had a high-grade nodule, you'd be more aggressive about following up the patient than if there was a bit of emphysematous change and everything else was okay.
Yeah.
Somebody's asked specifically how many millisieverts of radiation per scan.
So I'm happy to answer that. We're not talking about millisieverts for the scan. We're talking about what's called CT-DI-vol, which is another radiology acronym. But what it means is it's like how intensive was the radiation being pumped out. It's like saying, you know, how heat efficient, you know, is your fridge or your washing machine. You know, how much energy it uses depends on how long you run it for. So we talk about what is the output of the scan, because if you have a person who is, say, twice as big as the next person, they're going to get twice as much dose. And so the overall dose is very variable. So we use a CT-DI-vol of less than 3 milligray per square centimeter. So that's, in this day and age, it's achievable, but it is low dose. And you should be routinely getting the vast majority of our participants scanned under that scan range. In terms of what it means in terms of millisieverts, on the whole, as a rough ballpark, for the average size person, we're talking 1.5 millisieverts.
The questioner then said, well, it's probably an irrelevant question because their smoking is a much bigger risk than the risk of
well, let's not add to the risk of making cancer develop. Yeah, that's right. So it's an important part of the program. We have to report on our radiation doses in every single report that goes to the register as well.
Okay. A couple more questions about follow-up. So one person has said, so if a patient is not a regular patient of a clinic, the GP should be directing the patient to their regular GP for lung cancer screening. We're seeing a lot of fracture of care at the moment with, you know, politically what's happening. So I think people have got to find their own solutions to that. Somebody else has said, I had a patient we tried to contact via email, mobile, registered mail about an abnormal scan, but they ignored all forms of contact. So, and then they said registered mail and it was sent back to the GP clinic. You have my sympathy. That's a very awkward thing, but you've documented everything you've done. I think that'd stand up in court if there was an adverse reaction.
And then
Any
also
more questions?
the register follow-up also kicks in as
That's
a
right.
particular.
So, I mean, that might have not been the low dose lung cancer scan. It might have been another example of follow-up of abnormal results. But yes, that's one of the benefits of the lung cancer screening program, is that there is that extra safety net of the National Lung Cancer screening. And you will send reminders when the patient's due for their follow-up scans as well, Dorota.
Yeah.
Yeah. So even though we'll use our recall systems as a backup, the cancer screening register also does that. Does anyone have any other questions? Because we've got these wonderful speakers that we can utilise.
So I have a question for Catherine. How easy is it to chase up prior CT scans, and is there any movement in an initiative to have some form of national radiology register or repository?
So yeah, so it's the bane of a radiologist's life, chasing previous results and previous images. The reports are generally pretty easy to get hold of, but images, of course, is a little bit more complicated. So the more information we have about where the scan was done, and sometimes it, they say, oh, I think it might have been Warrnambool in about 2017. Okay, right. So, our admin staff like playing Sherlock Holmes and going, solving the mystery of where it was. But the more information we can get, the better. So if they're able to even tell you, was it the clinic with the red sign, the yellow sign, the blue sign, just something. A lot of radiology clinics participating in this program are giving the participant a questionnaire when they arrive. And on that, and then we're all making our own, but they're all kind of the same. And on that, it says, where have you had your imaging done before? Because even if we know that perhaps they've gone to a hospital somewhere in the last, say, 5 years, but before that, it's a bit irrelevant. Or which clinic they might have gone to for something, even if they can't remember what they had, we know everybody in our local areas. We can ring them and say, hey, have you got anything for this person, for this CT type of scan? Yep. Okay. Can you flick us the reports? And then we'll look at it and go, yep, this is something we need to see. Can you send us the images? And so it is variable in different locations as to how easy it is to that. Oh, there's a question. If a private radiology closes, what happens to the images and reports? So all of the reports for this program end up in the NCSR, which is again another benefit of registering. But also it should go to My Health Record, and the report should go back to the referring doctor. Oftentimes the participant themselves will get a copy of it as well, because they can download that themselves. What happens to the images is a bit more challenging, because there is no national, data sharing archive for this program. If it completely closes, there's usually a legal requirement that you must retain the images for up to 7 years afterwards, even if you close your doors. Of course, it's just harder to access the images and get them sent to you, but they should be retained.
Dorota, how long do you think we're going to have to be running this program before we can say this is making a difference to outcomes in lung cancer?
Well, that's a really good question. We're obviously monitoring the data already. It is very early days, and
yeah,
I can't really say at this point, but I think fairly early on we should be able to see the increasing proportion of early stage diagnosis. And yeah. I recall, and Catherine might remember this as well, there was a presentation from one of the UK group at the ALCCC, and they talked about an early stage shift that they saw within, I think it was within about 6 months. And what was really great to see was also the stories that were coming out from patients, and that was encouraging people to get screened when they heard those stories as well. So I imagine we'll be able to see it quite quickly, but yeah.
Well, certainly anecdotally, I work at the Royal Brisbane. There's in my lung cancer MDT, we've had to set up a new lung nodule management meeting because of the number of stage 1 cancers that we're getting referred through, which we just weren't seeing before.
Which is great. Like,
Which is
sorry that you're
the whole
working
purpose.
harder. We
The
all
whole
knew
purpose
that
of
you
it.
need to. But yeah.
But I mean, you know, the whole point of it is that we then don't see as many stage 3s and 4s. And that's probably going to take, we think, maybe 2.5 years before we can see data that proves it. Because we're going to see a lot of historical cases coming through for screening that could still be stage 3 and 4 at diagnosis. Whereas when people start coming back for second rounds of screening, you know, we're going to see the lower risk group where we might start seeing new cancers developing at stage 1. And so it'll
Because they've
probably
developed in the
take,
last few years. Yeah.
correct, yeah. But we're already seeing them. I've seen a number of cases come through that I thought, goodness me, thank God they came in on day 1 and not in 2 years' time, because this is still curable. Yeah.
And that's the whole point. We're looking for a cancer and trying to make lung cancer curable instead of a death sentence. Is kind of what I said earlier. Is there going to be, I'm not aware of public outreach, promotion of the program to say to the public, ask your doctor. There's no signs on the back of toilet doors like there are for pap smears and
condoms. Yes, but absolutely, absolutely there are. So the official campaign to promote directly to the general population began in the last few days of October. We had sort of decided that we would do a slow burn sort of approach to this, which sounded great in theory, except we hit the ground running and everything was suddenly frantic from day 1 and it hasn't slowed down at all, which is
you did such
fantastic.
a good job of educating GPs to defend their patients.
Yeah, well, that's right. And so, but the direct media outreach started a couple of weeks ago. And so soon enough, you'll be able to see it on bus stops and on the radio. I heard something on the radio up here actually last week. I don't listen to the radio very much, but I heard an advert about it and I thought, oh, there you go. I'll see that person that they're talking to, you know, in 2 weeks in my clinic. So it is definitely ramping up in terms of direct awareness within the general community.
And what's the realistic expectation for turnaround of results?
Yeah, so that's a very good question. Just like how all of the GPs and every other craft group involved in this are learning the ropes, I've had to, well, me and 5 of my colleagues have done a series of roadshows for radiologists around the country where we've now done one-on-one workshops with 1 in 5 radiologists around the country. Okay, so that's over 500 radiologists around the country have had hands-on workshops now. So it's taken a while for people to get the experience in how to get the results back. And of course, when you're learning something for the first time, you might ask a friend, you know, mentoring. You know, I've mentored a number, about 20 or so radiologists to be able to feel confident to fly solo, as we call it. There's no requirement to double read these cases, but when someone's learning anything for the first time, and this is very new for us in radiology, there is that, what we thought, we hoped we'd get a slow burn of uptake so we could pace ourselves with it. But there has been some delay in report turnaround across the sector for the first few months. But that seems to be, from speaking to all my colleagues that work in different places, that seems to be getting under control again now. Yeah, so great job sending all of your cases. Keep sending them, because, you know, I think we're at the point as a sector where we're ready to take as many as we can get.
That's awesome news. The first one I sent took 2 weeks, but it may well have been one of those, you know, I'm a newbie at this and I want to get things right. So
I'd rather make sure that I get it back correct than get it back same day, but it's a load of rubbish.
And it's a screening test. Like, it's not like I sent them and 2 weeks is too long to wait to find out if they've got pneumonia. So this is an asymptomatic patient, so we have to have realistic expectations. There's another comment about surprised by the increased findings, because, you know, trauma cases in ED have pan scans, and, you know, in a population where there's a lot of smokers, it wasn't common to find lung cancer, but maybe they weren't looking for nodules when they were doing pan scans for trauma.
Well, they probably weren't looking for nodules. They probably weren't also reporting on coronary artery calcification or reduced bone density. And again, this is contextualizing how that participant is presenting for healthcare. I do a lot of trauma reporting, and when I report that, I certainly deliberately do not talk about reduced bone density. I'm too busy telling them whether there's any fractures or dislocations. So this is a very specific way of reporting a CT chest. It's also not giving any intravenous contrast and to reduce the radiation. Like, everything is different about this type of CT when you walk in. And I think, Martina, you said, if you're so short of breath, you can't lie down for 5 minutes with your arms above your head. I 100% think if you can't do that, you're probably not suitable to come and have a CT. But it does take only about 20 seconds to do the CT. Because it's a non-contrast study. We don't put a drip in, there's no dye. I got
that from the actual lung cancer screening program documentation. So that's what they say. But I agree. I
think written by a radiologist, that one. But I will say, though, that most of the time when people can walk into the clinic, we can get them onto the table and get them scanned, and they, and sit them back up, and then they're okay. But if your participant, your patient is so unwell with comorbidities that it just comes back to, is it really suitable to screen them for lung cancer?
Should I be screening?
Yep. And that's really where if they can't lie down flat for 5 minutes, well, maybe actually there's something else going on.
Maybe we need to treat their heart failure first.
Yeah, maybe it's a different type of referral. But also, just getting back to the eligibility and being asymptomatic, it's asymptomatic of symptoms of lung cancer. So if you have someone who's, got a chronic cough, well, that's not really a symptom of lung cancer if they've had it for years and you think it's because they've got asthma or, and a lot of these people are still smoking and they have a smoker's cough. It's a different story with weight loss, fatigue, hemoptysis, okay, maybe they're symptomatic of lung cancer and they should have a diagnostic study, not a screening study. But, realistically, you can have people with terrible emphysema, COPD, fibrosis. All of those people are at increased risk of lung cancer, even amongst this smoking group. So if they're able to have the CT, the official program guidance is to be inclusive and to, talk to them about participating and to encourage them to and not put obstacles in the way.
I guess the other thing is that we need to be considering symptoms of lung cancer because then they need an investigation, right?
Well, either way, they need an investigation. Yeah, that's right.
But, anyway, so I thought that questionnaire, that online questionnaire that you can put your patient through if they've got symptoms, is really helpful for people to know about when they're making that decision. We haven't had any other questions that are significant. So unless anyone's really, really quick on the typewriter, we might give people an early mark. But
a bit of an early mark,
I do need to say thank you to both of the other speakers and Tammy, because hopefully it's been a really practical addressing of the program, and people feel a lot more confident about it and able to counsel their patients before and after the test, so that it becomes part of our usual workflow. So I'll leave it to you to close off, Ruby.
And thank you to you, Martina. It's definitely been really helpful to have a GP perspective as well, I'm sure. And a big thank you to everyone who attended this evening. Just a reminder that an evaluation survey will pop up at the end, and we really appreciate getting your feedback for future events. And thank you so much, and we'll see you online again soon.
Thank you, everybody.
Thank you, Ruby. Thanks, Martina.
Thanks.
Thank you, everyone.